Hola, Internet. Buenos dias de Mexico. Evan Benton of Dogg for Mayor here, and today I'm going to be talking about the first and only human challenge study for the disease that I'm afraid to name on YouTube. This came out 2 weeks ago, so I'm a little behind the ball. I'm surprised that I hadn't read this earlier, but I'm reading it now. I read it yesterday, actually. This is going to be my notes on it. And so a challenge study or a transmission study, experimental transmission, is where you infect people or try to infect people with a certain disease to try and study how it is transmitted. And I've covered this a few different times in the past, talking about how they basically don't work. These studies don't work, and this is a massive Achilles heel for the germ theory proponents. So yet again, we have a failure to transmit the disease. I'm going to just go right to the notes or to the documents I'm going to be looking at today. So here it is, the first transmission study for the disease. The title down here: Safety, Tolerability, and Viral Kinetics During the Disease Human Challenge. So you can tell right away it's about safety and tolerability, and viral kinetics is a fun way to talk about transmission itself. But we're not going to be talking about how the disease is communicated from one human being to another, which is disappointing to me. But you'll see what this is about throughout the course. Okay, we're going to look at it basically from a policy angle. And essentially the point of this study then is it's like a pilot program to develop the methods that they're going to be using in the future, hint hint, for any kind of disease that might come about. They now have a framework. And so February 1st is when it was released, and it's not been peer reviewed. Okay, this is not an official publication, so very exciting. We're getting here on the ground floor of some cutting edge research. And so as I do, I don't always look at the study just in a vacuum. I try to look at what went into making this study, and this is going to be no exception. In fact, as I mentioned earlier, I'm mainly going to be talking about the background of the study, because the study itself is pretty bogus. 36 people. You're not going to learn a lot about an epidemic by studying 36 people, regardless. And as I said, they're not trying to do that here. But so anyway, I found this article looking up the ethics of human challenge studies. And so wouldn't you know it, the World Health Organization recently had an ethics review of the disease human challenge studies. This is a joint workshop with the NHS. You probably can't see that, it's hidden behind my face, but NHS is the United Kingdom Health Authority, and World Health Organization, of course. So this was actually a committee that was founded, or whatever you would call it, just a work group that was founded to study these human challenge studies, and it actually led to the very same study that we're going to be looking at today. So this comes out of the World Health Organization. That's important to understand. So and this is pretty short. It's 11 pages, but most of that is citations. So it's only 5 pages, and we're not going to cover all of it, so don't worry. Anyway, so my first point starts with this sentence. However, we say human challenge studies are not usually undertaken with a novel pathogen in the midst of a pandemic. So keep that in mind, folks. We don't usually do these types of things, is what the World Health Organization is telling us. And then, so most of this is about just why and how we're doing what we're doing. Okay, and it's all about here's the criteria. The World Health Organization key criteria. They came up with eight criteria that a proposed challenge study has to meet. Okay, and these are all pretty straightforward. Okay, scientific justification, benefits must outweigh the risks, consultation and engagement with the public as well as relevant experts and policymakers. So policymakers is number 3, and then policymakers is number 4 too. So a quarter of the points then we're saying are directly related to policymakers. And that's another point I want to underscore here, is we're mainly looking at this event, this so-called disease, from the perspective of policy, okay? And and you can read the rest of it. Coordination, of course, expert review, right? Expert review by a specialized independent committee. So again, this is this is what we're kind of saying, is that the people conducting these reviews or the people conducting these studies are supposed to be these independent committees, or I guess you could say that the World Health Organization is supplying this independent committee. And then, of course, informed consent, Nuremberg Code, we're all familiar with that. And that's not been violated at all. Big question for me with it, is this really the first study? Okay, I can't believe that we would have gone 2 years without just trying to get people sick and see if this works. I mean, of course, there's going to be some ethical concerns there, but there's ethical concerns with every other action we've taken, and I find it hard to believe that people would not sign up for this sort of a experiment, but would be just fine with having their livelihoods destroyed, on and on and on. I don't need to belabor that point in this video. It does appear, though, that yes, as we're saying, the UK was the first and remains the only country in the world to commence the disease human challenge studies, okay? And so that's this, again, we're referring directly to this study that I'm going to be looking at later. All right, and then for the scope of the study, up to 90 volunteers were planned to be involved. Okay, that's just this part. Up to 90 volunteers were planned to be involved. And our study is going to be 36, as I said. Actually, they dropped it down to 34, but 90 is the maximum we're looking at. That's pretty low. That's not going to give you a lot of useful data, when you start talking about probability of things, happening randomly versus, demonstrating that, the effect that we're observing is really relevant. And then this next paragraph says that yes, there is a second study. So there is a second study on the disease and experimental transmission. This one's called a dose-finding experimental human infection study with the disease in healthy volunteers with previous microbiologically confirmed infection, and that's here. And this one's still ongoing. We haven't gotten any results for this study yet, but this is the article. This is the clinicaltrials.gov website that I'll put a link to below if you want to follow up on that. The last update was January 20th, and I can't remember when it said it's supposed to be completed November 2022. And one of the strange casualties of the event, as I've been calling it, has been the idea of immunity, okay? So this is just, I think we all kind of learned in grammar school, even people who don't have much of a background in science have this idea that once you get a disease, you are immune to that disease. And that's just gone out the window with this whole thing, right? Variant after variant. The natural immunity is just useless. Even the biological infections are barely any good at all from what they're telling us, and yet we have to keep submitting to them. So the rationale there is just, it doesn't make any sense to me. It doesn't make any sense to a lot of people, but so that's what we're looking at. And so what they're saying, the aim of this study was to establish the lowest dose of the virus challenge strain, which could cause infection in 50% plus or minus 10%. So that means 40 to 60% of individuals who have previously been naturally infected. So the rationale is no matter how immune you are, or how immune your group of subjects are to this disease. There's a certain threshold, that they're calling nowadays viral load, where 40 to 60% of those people will succumb to the illness. So that just flies in the face of everything I've ever learned. But I just wonder, are we gonna have our history books rewritten now to say like that people were getting smallpox 2 or 3 times, back in the 17th or 18th century? Just absolutely crazy to me to be reading this. Now, okay, next section just says, overall, the workshop participants agreed that the World Health Organization key criteria document is a valuable tool for providing an ethical framework for the review of the disease human challenge studies, and in particular lay people who were not familiar with human challenge studies found it valuable. So we're just patting ourselves on the back here. And next section on the same sort of thing. In addition, in order to reduce potential bias in favor of human challenge trials, the committee was purposefully, it should read, designed to include members who did not have human challenge study review experience. So you see the little legerdemain they pull there. They're going to construct a committee composed of 2 groups of people. Groups who are in favor of the human challenge studies, and another group of people who do not know anything about human challenge studies. And they're telling you that that is going to result in an even-ended, non-biased opinion on human challenge studies there. I think the problem is pretty self-explanatory there. And for the record, I am, of course, in favor of human challenge studies, especially when we're comparing them to shutting down the entire economy of the world and the thousands of deaths that may have caused. But I digress. So again, researcher experience similar to the above. Overall, researchers observed that the World Health Organization key criteria built confidence and provided reassurance regarding the potential international acceptability of the disease human challenge studies. So lay people and the researchers themselves who are familiar with the human challenge studies both pat themselves on the back over this experience. So, what a surprise. We paid people to tell us that this was a good idea, and they came back and told us that it was a good idea. Here we are. Next, I want to pull out, this work demonstrated broad support of the disease human challenge studies in the UK population. As I was saying, of course, if they had presented this to the UK population in, say, May of 2020 and said, hey, if we just take a couple of y'all, we already know in May of 2020 that this disease only affects people over 65 who have diabetes and heart disease and are overweight, I think they would get just droves of 20-somethings as the likes of which signed up for this study. I think they would have gotten droves of 20-somethings at that time. And then we're saying multi-level communications strategies coordinated with specific public engagement activities are arguably essential to the acceptability of the disease human challenge studies. These activities would ideally involve experienced social scientists and be independent of the human challenge study research team. Right. So up here, we're saying that we've got broad support, but arguably, where did that say? Arguably essential. So I mean, yeah, arguably, I would, put the emphasis on the word arguably there. Arguably, we still need, we still need a propaganda campaign, basically, to popularize or to explain to the people why these things are so essential. And that's just, it's a bit strange. But so social scientists are a big part of that. And I'd like to talk more about social scientists in the future. That's sociology, anthropology. I'd refer you to the Union of Concerned Anthropologists, whom I often cite. There's a big problem here with people have used these social sciences to basically learn how to control people, learn how to control masses, and that's what they're doing with these types of studies. Now, top of the next page, despite the availability of, I'm going to call them biologics, the disease-human challenge studies may still have strong scientific justification. So this is just insulting to me. I just wanted to pull that out and just remark upon the the ridiculousness of it. Okay, so we've got the magic potions, and now we don't need to do any more research. No, in fact, well, we don't need to even verify the acceptability or the effectiveness of the magic potions, right? In fact, they're going to go on to say that, of course, right? We need to assess the magic potions, right, and then make sure they're still working. But even still, I just had to pull that out, and then that's about it for the rest of this paper. Conclusions. I'm not going to talk about the rest of this. It's just patting each other on the back and talking about the policy implications. Of course, no declaration of interest. All declarations of interest forms submitted by external contributors were reviewed and assessed, and no significant conflicts of interest were identified, so we can all sleep very soundly at night. The funder of this meeting was the Wellcome Trust. So if you didn't just assume that the Wellcome Trust has ties to eugenic groups, etc., Bill Gates, sorry to disabuse you of that notion, but interesting thing that I found them looking at is something called the Wellcome Global Monitor, and this has been put out since 2018, and it is just a survey of people's opinions about medical doctors and about science. Okay, so in 2020, this is I don't know, the second or third publishing of this big survey poll, and they're asking people the questions, how do you feel about science? How do you feel about scientists, et cetera, et cetera? And we'll just scroll down to, I believe, page 3, where they say, globally, people were more likely to express a high degree of trust in science and scientists in 2020 than they were in 2018. There was a 10 percentage point increase in people saying they trust science in general a lot, while the percentage who said they trust scientists in their country a lot rose 9 percentage points. So now this is probably early in 2020. Obviously, it's after March and April, but I'd say the earlier in the year you were going to ask people these questions, the more likely maybe you get people who weren't totally tuned out. But it really depends on who you ask with all these poll things. At any rate, lies, damn lies, and statistics. If we could trust the polls, Hillary Clinton would still be president, right? So, all right, on to the study itself. And here it is. This is the PDF version of it. Safety, tolerability, and viral kinetics during the disease-human challenge. And first of all, and I'm going to look at the people who are doing this work, right? First of all, just I counted 31 authors here. So for a sample size of 34 subjects, that's almost a 1-to-1 ratio of researcher to subject. And the paper itself is only, I think, 15 pages of text. So that's like, a paragraph per author. But most of them anyway are, and that just underscores that we're not really looking at the subjects. We're really looking at the researchers, okay, and the different groups, right, the schools. So and most of these are just schools, right? London, I don't know where else. UK Vaccine Task Force, probably someone with the government. But this one is what comes up a lot, H. vivo. So my first question regarding the people involved was, of course, who's H. vivo? So we'll look at their company. Open Orphan is the name of the company who owns H. vivo. So if you scroll down, you'll see H. vivo on the left, and Venn Life Sciences, which was, I guess, the original name of the whole thing. So Open Orphan is a rapidly growing niche CRO pharmaceutical services company. I believe CRO is a contract research organization. Contract research something. Anyway, so that means they do research commercially. You hire them to do research, and there's no problem with that, of course. A world leader in the testing of the biologics. Okay. And just a funny name, Open Orphan. Right, so the world leaders in human challenge studies. So, gotta be the world leaders. We're working with the World Health Organization here, right? And we're gonna get a little bit of information about the study here, which is that it's taking place then at H. vivo's 24-bedroom quarantine clinic, which is located in London. And so that gives us an idea of how large a study we can hope to accomplish here, right? 24 bedrooms, and it gives you an idea of what goes into this. Okay, 24 separate isolated rooms for each person, and or one each for 24 people, 24 hours a day care and monitoring. So that's pretty impressive, and resource intensive to be sure. Right. Oh, Europe's only. That's the other part I meant to say. Europe's only 24-bedroom quarantine clinic. So it gives you an idea that the global capacity for these types of studies is not very high. And as I mentioned before, if it's, this is the Achilles heel, this is something that the germ theory proponents really want to be strengthening, right? And then here, as I'm looking at, yes, this is the world's first challenge study model for the disease that we're looking at today. So, Open Orphan, what does that mean? Not a 90s grunge band as I thought it was. So it refers to the term orphan drug or orphan disease, which, if you're a germ theory proponent, are the same things, right? Anyway, an orphan drug or an orphan disease is one that's been studied, but they found that there's not enough patients to make it be profitable to continue studying it. So they've stopped studying it. They might have started developing a drug, but regardless, there's no more money in getting that drug to the market. So this is where companies like Open Orphan comes in, and open means like open source. So that's sort of a strange thing that they're doing. They're trying to open source the research. How do they make money off of this is, of course, the question. And obviously, then they're going to make money by developing the process that can be used for multiple different diseases. Okay, so that's what they've done. They've got the 24-bedroom quarantine clinic, the only 24-bedroom quarantine clinic in Europe. They have cornered the market there on that, and we can immediately see how that is going to benefit the mRNA injectable approach, as considering the mRNA as a operating system that they can just swap out the contents of depending on the disease. So now we're going to have a HIV injectable brought to you by Moderna. Next is going to be an AIDS injectable. Diabetes injectable, cancers injectables coming down the pipe. And obviously, in terms of the other World Health Organization paper talking about an independent people to oversee this kind of thing. Well, we're talking about a single point of failure here with Open Orphan. So if these guys are bad actors at all, if they have any incentive to cheat and to give us faulty data, They're the only people who are doing this type of thing, okay? So it's impossible for there to be any oversight. It's impossible for anyone to properly peer review this research because no one has the facilities to replicate it. So there you go. Now, another interesting connection we have is FluCamp. This is a really bizarre kind of thing. So this is FluCamp is their public relations wing, okay? And they are recruiting, how it says right, they're recruiting in Manchester for the quarantine facility in London. And this is this whole weird thing. They've got videos. It was an empowering experience. I mean, they're literally kind of doing a reality TV. That's right. They're going to do some sort of reality TV project with people going to FluCamp, and yeah, they've got a lot of videos on Vimeo, and so that's a little bit out of date. So it gives you an idea of where they're at with this type of stuff. A couple screenshot captures from those videos that are going to relate to the study. So the benefits of this type of study: no seasonal constraints. And I know this is hard to read, but that's what it says there. No seasonal constraints, which they don't consider to be a problem because you can just inject someone with any disease at any time. But we know that there are massive seasonal constraints on such diseases that they're studying, like the flu, right? There's definitely a peak for the flu in the wintertime. The big disease that shut everything down that I don't want to name has big seasonal constraints as well, right? There was a big peak around the spring equinox, and then again the autumn equinox, and it replaced, funnily enough, it replaced the flu for an entire year, but that's another big seasonal constraint. And then here's a clip. I'm going to be referring to this when I get into the study and talking about the study. This is a guy who's just had the someone else's snot basically squirted up his nose, and now he has a clamp on his nose for an indeterminate amount of time, okay? And this is what they're saying is, this is the experimental transmission itself, okay? So in order to get any results at all, they've got to squirt a certain amount into your nose and put a clamp on your nose and have you sit there for a certain amount of time. So just, critical thinking question, what does that have to do with reality? What does that have to do with, sharing a drink with your friend or getting coughed on or something like that, okay? And I have to say that this is from a flu study. I found this on their Vimeo account talking about the flu, but they didn't give us any videos for this study, so this is the best we can do. We're going to assume that this is, a similar procedure was done to the disease we're studying. And then furthermore, what's the placebo in this case? Do you just inject them with saline and then put something over their nose, or do you inject them with snot that's been heated to 140 degrees, right? We don't know. We don't know what happened, but interesting questions, I think. So now, regarding the seasonality, we're just going to talk about this article just to bring that up, okay? So on 25th of March, the first volunteers for the challenge left the quarantine. So that gives us an idea, okay? And I just want to read here. The chief investigator for Imperial London College says, "We're pleased to confirm the first group of 3 healthy volunteers has now successfully completed the first stage of the trial." So that gives you an idea of the size of the trial again. 3 healthy volunteers. That's not 24, kind of what I was hoping for, but here, March 25th. So, they got out no later than March 24th, which puts us right at the end of flu season. And it also coincides exactly with the spring equinox. So if the spring equinox causes, diseases or has an effect on the appearance of a certain disease, that's going to be very important to know about. Of course, these people haven't heard that theory at all, but now they were in good health. Okay, so they didn't get sick, or well, I guess I can't make that claim because we're gonna find out about their health and the way it worked in the study. All right, and now to the study. So I'm going to wade through this 2 pages of authors, come down to the abstract. Okay, first sentence, to establish a novel disease human challenge model is the goal of this study. So again, we're not looking at the effect of the disease in the human subjects. We are establishing a model, a novel model. And we're looking at 36 people, which was later dropped down to 34 because 2 participants were excluded from the thing due to seroconversion. That means they tested positive for the disease before everyone was meant to be inoculated. They got naturally inoculated then, according to the available tests. The subjects were 18 to 29 years old, so it would be remarkable, really game-changing if these people were to get sick at all, because as we know, in 2020, nobody under the age of 65 and not diabetic, not with heart disease, and not overweight had any serious health outcomes due to the disease. No one in this age group had any effect until they started getting the injections, but that's another story. And so, as I said, 36 subjects, we're not going to learn a lot about the effect of the disease itself, but I'm going to make some, I'm going to pick out some observations, okay, that they claim to have found. So, first of all, viral load rising steeply and peaking at 5 days post-inoculation. So, what they're doing is, and this is what's good about this type of a study, is every 12 hours, I believe, they were swabbing these people's noses and throats, testing them for the disease using a quantitative PCR, which purports to measure the number of units of viruses. And they found, there's some graphs in here I'm not going to look at. If you want, you can look at them on your own. But basically, they found that, the number of viruses they recovered rose steeply and peaked at around 5 days, and then dropped. And my question, coming from a Bayesian perspective, not from a Pasteurian perspective, is the body just getting rid of this stuff? So again, we'll go back to this stuff. He's had some snot from another person. It's not quite that simple, but he's had some snot, we'll say, squirted up his nose, and then he's got this clamp on his nose, and he's supposed to sit there and let the clamp, let the snot soak into his tissues. So they noted, where was it? Here we go. They noted that the virus was first detected in the throat, but then rose to significantly higher levels in the nose. So maybe just gravity is pulling that stuff down into the nose, or into the throat, excuse me, post-nasal drip type of thing. And then maybe it's more deeply absorbed into the folds of the nose and the nasal cavity and everything, and maybe it just takes a little bit longer to drip out of that. That's an interesting question, though. The effect of gravity on infectious diseases. Of course, what we saw with the disease we're studying is we saw the ground glass opacities in the beginning of the March and April 2020, where that they were seeing this fluid buildup in the lungs, which comes from the fluid coming in from out of the upper respiratory tract and then just dropping down into the lower respiratory tract and not being able to drain any further. So yeah, is the body just getting rid of this stuff, and is that why it's peaking? It takes about 5 days to get rid of this stuff. Interesting question. And then no quantitative correlation was noted between viral load and symptoms. with high viral loads even in asymptomatic infection, blah, blah, blah. So no quantitative correlation was noted between viral load and symptom. There's no relationship, in other words, between presence of the virus and symptoms. There's no, there's no relation between the person having evidence of this organism in their body and then actually being sick. And many other studies have found that same finding, and they say that this is evidence that of asymptomatic spread, right? But maybe it's evidence that there's no correlation. Again, only 36 subjects, but elsewhere in the study, it's going to say, quote, overall, peak viral loads reported in natural infection are lower than those observed in this study. So they're working on a very low number of viruses. Viruses is sort of a funny term, to try and get the results, because they're trying to establish a model. They're trying to do this as safely as possible. They're trying to determine the smallest dosage that can get the results they want without hurting people. And well, actually, this is what the other study, remember I mentioned the second study, that's specifically what they're finding, right? What they're looking at is the dose finding infection study, or reinfection as the case may be. But as to drive the point home, they're using a 10 TCID, and let's see, what does TCID stand? TCID 50 is the dose it takes to get 50% of your, oh gosh, I can't remember what this stands for, but this is they put little petri dishes basically and infect them all with a certain amount of the virus, and when you get to the point that they put like 1 drop in and then 2 drops in, and when 50% of the petri dishes have become infected, which they can measure in different ways, then they say that's your TCID 50 for that particular virus. And in this case, elsewhere in the study too, it's going to say they actually want 100 TCIDs, TCID 50, and they went ahead and used 10. So they went ahead and used 1/10 of the recommended dosage, just to drive the point home. So the assumption, as I mentioned, were naturally infected people having higher viral loads. The assumption is that that's because they are getting tested later in the disease process. So they're coming to the hospital after the disease has already ran its course. That's the assumption. That doesn't really make sense to me, because we've had such a run on the hospitals, we're told, that I think that they've been testing people a lot earlier and at different stages than that. But anyway, there's no quantitative correlation between viral load and symptoms, according to this and many other studies. And so the one good thing, well, maybe not the one good thing, but another good thing that this came out of this study is that lateral flow results were strongly associated with viral virus and modeling. So lateral flow, I don't know if you've heard of these. They're big in the UK, I guess. They're a type of rapid test, kind of like just a P-strip looking, pregnancy test looking type of a thing. And what this study found is that they are basically pretty good compared to the PCR test. And I've gone into the PCR test. It's not too good itself, at any rate. But the one thing, or they managed to sneak into this study a little side quest that they could use to claim that the lateral flow results were useful. Even when they are, imperfectly implemented, right? And wouldn't you know it, the company that is sponsoring this conducting this research, Venn Life Sciences, oh, here it is. It's actually H. Vivo COVID Clear. Oops, said the word. They do a full line of disease tests for the disease. So that's a bit of a conflict of interest, but they've managed to assuage their customer base at the same time that they're finding out all this other interesting data. And so anyway, long story short, of course, they didn't get anybody sick in this study, which would be surprising using looking at their subject base, right? 18 to 29 years, it would be incredibly interesting if they managed to get some people of that age group sick. But they're calling this a good thing because they're trying to, first of all, develop a safe model for the test. Okay, so they basically found no symptoms. Okay, nobody got sick, and let's see, where is it? No serious side effects. Mild to moderate symptoms were reported by 16, which is 89%, we got to say, of the infected individuals. 16 out of, oh no. Well, anyway, it's not 16 out of 18. It's 16 out of, I believe, 18 was the number of people who got infected, which was like 2 in the control group, and then 16 out of 18 in the study group. But anyway, mild to moderate symptoms, anosmia, not being able to smell, or dysosmia, not being able to smell very well, was something that showed up much more often than it seems like in the general population. So that's very interesting. And then it also developed more gradually. So in 12 of the participants, 12 of the 18 participants, I believe. And that's really strange. So it's going to go on. I didn't write this down, but these people lost their sense of smell, having not even been sick. So that's basically like the only notable symptom is, oh, suddenly I can't smell, and that's just really strange. And my question there is placebo effect. What's in the placebo? Okay, and what effect? Just going back to this guy, what effect is just having a clamp on your nose and your nose being full of gross stuff going to have on your sense of smell? Okay, so have they first of all, figured out what this is? I assume they have, but I digress. So the placebo, is the placebo saline? Because no one in the placebo group developed anosmia. Okay, so if the placebo is saline, maybe the suggestion would be that we need to use a different. Maybe we need to use. Okay, as I said, assuming that it's snot, which it's not, but something like that. Maybe we need to use something like sterile snot to see what the effect of that would be. Okay, but even then, it's an interesting kind of thing that they're using to just support the status quo. And I would say that's interesting, and maybe it bears further looking into. Maybe it doesn't really support the status quo that way. And so elsewhere in the article too, or sorry, the study, it's going to say that they had a rescue therapy or a rescue treatment for these people. So if anyone got sick, if any of the 36 young people did get sick from the disease, they were going to treat them with monoclonal antibodies. And that never ended up being used, but that was what they were going to use. So that gives you an idea of how sick they got. Not sick at all. Not sick to require any form of intervention, they say. And then, and no consistent pattern, it also says, not in this paragraph, I don't believe, but elsewhere in the study, says no consistent pattern was observed, whereas we did see a clear presentation with the disease in the general public. And if I were to be cheeky, I might cite a little quote from later in the article. Okay, I'm going to do it anyway. Quote, "There was no difference in symptoms between remdesivir treated and untreated individuals." So yeah, part of the study, they were treating people with remdesivir, and they changed the design of the study halfway through because they saw that the remdesivir had no effect. So that's an interesting little thing that, again, we're dealing with 36 people. We got to remember that there's not a lot to hang your hat on here. But this study, the human challenge model, the only human challenge model of the disease that has kept us home for years, found that remdesivir has no effect. Moving on now to the introduction. So the first sentence here, right? The disease is a complex clinical syndrome caused by the virus. Now we're going to make that claim, but that's never been demonstrated, okay? So it just bugs the heck out of me that they would go right ahead and do this. The last article that I made a video on did that too, I believe. And then despite all this research, you know, we don't know how any of it works. We don't know very much about this whole thing at all after 2 years. And well, maybe it's because we've never done any of these types of studies, these experimental transmission studies. We still aren't, but at any rate, this last sentence is a gem and a half. I can't select the whole thing. While human infection challenge has been attempted during previous pandemics, none have been successfully established, and no recent reports of the disease challenges exist. So that answers my question again, that this is the only such study, right? But look at this. None have been successfully established. And I wonder what their source is for that. Now, remember what I said in the World Health Organization ethics paper there. Human infection challenge is not used during pandemics, okay? And they're actually disagreeing, and they're saying, actually, it has been attempted during previous pandemics. It's just never worked. So what's this? What's this? Citation number 8, he asked leadingly. Go down to, I think it's page 17. All right. Oh, what? Rosenthau? No. Experiments to determine mode of spread of influenza? 1919? They aren't citing the Rosenthau experiment, are they? Okay, well let's pull it up, okay? JAMA 73, 311 to 313. Oh my goodness. JAMA 73, starting on page 311 by Milton J. Rosenthau. Oh my goodness. You mad lads. You cited the Rosenthau experiment. Okay, so, and this is the granddaddy of the whole thing, right? I mean, you can read this. It's only 3 pages. They had people coughing. They had people who had the Spanish flu. We all know about the Spanish flu. Patients who were sick with the Spanish flu, they had them coughing into people's mouths. They injected their blood. They had them spit into each other's mouths. A lot more, not a huge amount, like 100 or so people. 100 in all, it says right here. That's just one experiment. So here it says experiments, plural, at Gallops Island. So the Rosenthau article here, experiment, is actually going to go over a few different experiments. So over 100 people were studied. And they're just going ahead and citing that study, okay? 3 pages. I really encourage everyone to go and read this paper. And then while we're down here in the citations, the references, I'll just note, we got one study from 1919, and then everything else is going to be 2020, 2020, 2021, 2021, nothing else before 2020. And look at all these. We've got more, not that it's bad to have more references, citations, but we've got more citations than we have subjects, experimental subjects here. 39 citations, 34 experimental subjects. So it just shows that we're not really even looking at the subjects in this study. And the next page, the unique strengths of the human challenge approach are its ability to standardize the viral inoculum, study conditions and exact timing of exposure, thus controlling for factors that unavoidably confound natural infection studies, which, I mean, look at these. They haven't really supported the narrative either, but I digress. So this is a big problem, though. They're saying this is a strength. I'm saying this is a major weakness, and from what I've been able to tell online, a lot of critics of this study are saying the same thing. Standardized viral inoculum. So they're actually, the aforementioned snot is coming from a patient at the very beginning of the 2020. So we're not talking about any of these variants that have come up. This is at the very beginning, and we're still working on with that. So my question here has to be, what does that have to do with reality? Okay, taking whatever this standardized viral inoculum snot time capsule from 2020, squirting it up a person's nose, and then putting a clamp on their nose. Just to be dramatic, I'm showing this photo again. What does that have to do with what we all face as human beings, just walking around, picking up bell peppers at the grocery store, or shaking people's hands, or using the Taco Bell bathroom? Come on. So down to the results. I'm really going to skip this, right? So page 5 to about 15, the last 10 pages, I'm really just going to skip. I actually went over most of this when I was talking about the viral load and the lack of a connection between the viral load and symptoms, and the fact that the remdesivir was found to have no effect, etc. Basically, beyond that, surprise, surprise, the results justify everything that has been used as a countermeasure against the disease so far. So of course the quarantines work. The face coverings, I'm very tempted to talk about that, but face coverings is actually the word they use. They don't even say like surgical mask. They just say face coverings, which is not like anything resembling something that might be under like FDA supervision or anything like that. They're not all the same, okay? The idea that you can characterize something, lump them all under that, and have that have any kind of an effect on people's lives, or being, using that as like something to tell people to make them feel better, make them safer, ludicrous. And then of course the tests work, right? That's the other finding that they were paid to find. Even at-home tests work, and even when they're imperfectly implemented. So it's really just the whole thing is really just a perfect storm of just supporting the status quo research. And should any of us be surprised about that? I vote no. Wow, this has been a long video, but it's interesting stuff. I hope you'll agree. So in conclusion, we're not studying the disease at all. We're not studying the disease transmission in individuals or in populations, which is epidemiology, as distinct from medicine, right? Disease in population versus disease in individual, an entirely different toolbox, and set of presuppositions, et cetera. And the point of this study then basically was to establish a policy framework and a ham-fisted, you'll excuse the editorialization, a ham-fisted pseudo-scientific justification for said policies. And what we're really doing is we're really developing a better way to trick people into thinking that there's a disease going on. Not saying that is what happened at all, but with stuff like this, we're really creating a reliance on these globalist agencies and setting the stage for more of this stuff to come in the future. So now that we're sort of, we've got the trucker kind of thing going on, which I'm all in favor of course, but we're setting the stage for we're setting the stage for the next disease very most assiduously. We're not trying to get even trying to get useful data. That should be the take-home message. This study, 2 years into the disease that we're facing now, is not designed to produce data that's helping us with this disease. It's designed to help us fight super Ebola AIDS, or whatever comes next. So we got a long fight ahead of us, and you know, I'm here for it. Working on the translation of Béchamp's material. That's going to be hitting the bookshelves in stores near you as soon as possible. Until that point, I'm going to be putting out videos when I can, but I'm pretty busy with that. If you'd like to support my work, you can do so at the links in the description. You can also support my work by sharing it, by subscribing to the channel, by leaving comments, and by sending me any kind of an email or interesting, articles you'd like me to take a look at. I'll do my best to do that. So that's the end of this video. Again, my name is Evan Benton, and this is Dogg from Air. Thank you, and have a good night.